joining me today for Fighting Maternal Mortality Overdose Prevention, sponsored by Tennessee Initiative for Perinatal Quality Care. I'm Dr. Jessica Young, an obstetrician gynecologist and addiction medicine specialist, and past maternal medical director of TIPQC. In my practice, I focus on substance use disorder in pregnancy and serve as the medical director of Firefly, a substance use disorder treatment program for pregnant and postpartum people in Middle Tennessee. As obstetric healthcare practitioners, I know we all care deeply about maternal mortality. Therefore, we all have a role to play in preventing overdose, one of the leading causes of death associated with pregnancy. This video is created for healthcare professionals who take care of pregnant and postpartum individuals in any capacity. How many of you taken care of someone who struggled with substance use disorder in pregnancy? I imagine most of you could answer yes to that question. How many of you felt adequately prepared and trained to do so? My guess is that fewer of you would say yes to that question. Since the start of our opioid use disorder in pregnancy and opioid-exposed newborn projects, TIPQC has made it a priority to educate our healthcare community on best practices for this important issue and save lives in the process. There are 4 objectives for this session. We will develop an understanding of the significant role that overdose plays in maternal mortality nationally and in Tennessee in particular. This will help frame our time together and gives urgency to this issue. You will gain comfort with providing naloxone for overdose prevention and understand the role that naloxone plays in preventing overdose. In addition, I hope at the end of this presentation, you will embrace screening for substance use in pregnancy with use of a validated screening tool as is recommended by the American College of Obstetricians and Gynecologists. Finally, we will prevent relapse by treating opioid use disorder in pregnancy with medications for opioid use disorder or referring to treatment. We'll also talk about the role of stigma in creating barriers to treatment. We are all aware that maternal mortality rates have been increasing in the United States. However, many may not realize the role that overdose plays in those increasing rates. A study from JAMA Psychiatry by Hahn et al. Looked at maternal mortality from overdose before and during the COVID-19 epidemic. Across the nation, maternal mortality ratios increased and actually doubled during that time frame. Even prior to COVID-19, maternal mortality rates were increasing. The largest annual percent change was in overdose, with an annual percent change of 17.4% in pregnant and postpartum women. In this study by Howard et al., looking at trends in maternal mortality from 2015 to 2019, pregnant and postpartum women had higher increases in mortality compared to females of childbearing age in several categories, including all-cause, motor vehicle collision, homicide, and suicide. Overdose led all of those preventable deaths. We think that part of what is driving this increase in overdose deaths is the massive influx of fentanyl and other synthetic opioids into the illicit drug supply. This study from Bruzelius looked at U.S. trends in maternal mortality from overdose from 2017 to 2020. There was a significant increase in deaths involving fentanyl, with the most rapid rise happening between 2019 and 2020. The largest increase also happened during the late postpartum timeframe, a time when resources targeting this population may fall away. It is important to note, though, that overdose deaths during pregnancy also had an increase during this timeframe as well. Does this apply to us here in Tennessee? Unfortunately, yes. Our Maternal Mortality Review Committee data shows that acute overdose is the leading cause of pregnancy-associated deaths in Tennessee, with 86 maternal deaths from 2017 to 2021 involving overdose. The 4th highest cause is disease related to substance use. We can only speculate that substance use could be contributing factors in the other major causes of pregnancy-associated deaths: motor vehicle crashes and homicide suicides. If we were able to decrease overdose deaths, we would significantly improve maternal mortality in Tennessee. In Tennessee, like many other areas of the country, heroin has been replaced by synthetic fentanyl. Much like the national data, fentanyl was the leading substance found in acute overdose deaths in our pregnant and postpartum mothers in Tennessee. Often fentanyl is found as an additive in non-opioid substances such as cocaine or methamphetamines, which makes a lethal combination. Even small amounts of these synthetic fentanyls, far more potent than the fentanyl that is used for anesthesia, can cause overdose. Unfortunately, fentanyl is being pressed into pills that are virtually identical to other substances that people may be seeking out, whether that be benzodiazepines, stimulants, or prescription opioids. All of these characteristics of fentanyl and the drug supply now have caused overdose deaths to rise dramatically. Most of our maternal overdose deaths in Tennessee occurred in the late postpartum period, 43 days to 1 year postpartum. 80% of those deaths were preventable, and over half of those mothers had other mental health conditions. With an average age of 29, we are losing young people at the prime of their lives and forever impacting their children and families. These are grim statistics, but I hope by the end of this talk you feel empowered to make changes in your practice and communities that will save lives. Our Tennessee Maternal Mortality Review Committee, in their most recent report, gave recommendations that are relevant to overdose prevention. First, they recommended that naloxone be provided to all households that have a history of substance use disorder. The state was charged with providing outreach and assistance to pregnant women with substance use disorder for childcare, domestic violence resources, and employment. We, as healthcare providers, should screen and refer for substance use disorder in pregnancy and postpartum. We also should educate our patients and their family members on the importance of recovery, and we should be providing resources to them. Our health departments and Department of Mental Health and Substance Abuse Services are tasked with promoting and providing training for naloxone. All of these recommendations inform this presentation today and our learning here together. It is important to understand the concept of harm reduction, as both naloxone and fentanyl test strips are interventions that fit under the harm reduction umbrella. According to the CDC, harm reduction is a public health approach that focuses on reducing the harmful consequences of drug use, including transmission of infectious disease and the prevention of overdose. This is done through provision of care that is intended to be free of stigma and centered on the needs of people who use drugs. Historically, harm reduction practices have been conducted in community health centers, peer-led organizations such as syringe exchange programs, and health departments. More recently, there has been a movement to include harm reduction techniques in traditional medical settings. By meeting people where they are, metaphorically, we have the opportunity to not only save lives, but potentially help them start to engage in their own recovery, prenatal, and postpartum care. What is naloxone? Otherwise known by the brand name Narcan, naloxone is an opioid receptor blocker. It rapidly binds to the opioid receptors when it is administered and kicks off other opioids that are already acting on those receptors. By doing this, it reverses and blocks the effects of opioids that are already in someone's system. Doses range between 2 to 8 milligrams, depending on the preparation, but most commercially available formulations are 4 milligrams. Naloxone comes in an injectable form and a nasal spray. While the injectable form is often used in medical settings and by paramedics, the nasal spray is most frequently prescribed for patients to have at home. A side note, naloxone is not well absorbed orally. Suboxone, or buprenorphine naloxone combo product, is designed with naloxone in it to keep people from injecting it or snorting it. Taking it sublingually, very little naloxone gets absorbed, so it is not working as an opioid blocker in the setting of prescribed buprenorphine naloxone combo product. Administering naloxone to someone who has overdosed rapidly restores breathing. It is effective for 30 to 90 minutes, and thus it is important for someone to get medical attention for overdose, as long-acting opioids can still be active in someone's system beyond that 30 to 90 minute time frame. After someone has been given naloxone for overdose, they can be agitated and experience acute withdrawal symptoms like pain, nausea and vomiting, and diarrhea. Rare risks of naloxone are acute lung injury and allergic reaction. However, risks from naloxone are outweighed by the risk of death from overdose. Naloxone is unfortunately not prescribed as frequently as we need it to be. Data from the CDC shows that only one naloxone prescription is given per 70 high-dose opioid prescriptions. What is the data regarding overdose prevention with naloxone? In a CDC study in 2010 of community-based overdose prevention programs, 53,000 people were given naloxone and 10,171 overdoses were reversed. In North Carolina, naloxone distribution was incorporated into a community overdose prevention program, and a significant decrease in mortality rates were seen in that county. A study from Massachusetts showed that naloxone distribution and education on overdose prevention decreased overdose deaths in the communities where the intervention was conducted. The CDC defines those at risk for overdose as being someone who has overdosed in the past, people with sleep-disordered breathing, those taking benzodiazepines in combination with opioids, people who have been recently detoxed or released from a residential treatment facility or prison, people taking greater than or equal to 50 morphine milligram equivalents per day, or anyone with a history of substance use disorder, not just opioid use disorder. The FDA recommends that providers discuss naloxone with patients who are being prescribed opioids and consider prescribing them. Naloxone is strongly recommended to be prescribed for those who are taking medications for the treatment of opioid use disorder. For those with a history of opioid use disorder, naloxone should be considered regardless of time frame of last use. Given the number of overdoses in our communities, should we be prescribing naloxone with every opioid prescription for postoperative pain? An important public health issue besides maternal overdose is accidental overdose of children who access opioids in the home, whether prescribed or not. This adds to the list of compelling reasons to have naloxone widely available in our homes and communities. If someone is overdosing or you think they are, there are 5 steps to help save their lives. This education should be provided to patients, partners, and family members. The first step is to call 911. This is critical in case the overdose is from a non-opioid substance, the emergency is related to other medical reasons, or if 1 or 2 doses of naloxone aren't sufficient. Step 2 is to administer naloxone, whether with the nasal spray or injection. Step 3 is to try to keep the person awake and breathing. For someone trained in CPR, interventions for someone who is not breathing or doesn't have a pulse would happen in step 3. Step 4, lay the person on their side to prevent choking. Step 5, stay with the person until emergency assistance arrives. Tennessee has laws that protect a person who is overdosing and the person who called for help, so that people do not avoid calling for medical assistance due to fear of legal repercussions. Where are our opportunities to provide or prescribe naloxone in our obstetric world? We should offer and prescribe it for all patients with substance use disorder and family members or loved ones with opioid use disorder. During delivery admission, we should offer or prescribe it for all patients with substance use disorder and offer it to all patients who are being discharged with an opioid prescription. At postpartum visits, we should offer and prescribe it for all patients with substance use disorder. This is a picture of Dr. Kaylin Kiley and Rachel Duncan, a pharmacist who lead the Colorado Naloxone Project, which got many Colorado birthing hospitals to provide naloxone at discharge for at-risk patients. I urge all birthing hospitals to educate clinicians and patients on naloxone. Electronic health record reminders can be effective ways to remind clinicians to prescribe naloxone. Order sets with naloxone prescriptions built into them also can be ways to increase naloxone prescriptions. Nursing interventions regarding discharge teaching are also important practice improvements. By incorporating QI techniques, tracking and measuring naloxone prescriptions, we can effectively increase our naloxone prescribing and get this life-saving medication out into our communities. Even more effective would be to get actual naloxone kits for patients to go home with. This might require more work to implement on the front end, including creating institutional policies, which involve pharmacy and clinical leadership. Having funding for the kits themselves can be a barrier, but this could be accomplished through grant funds, donations, or partnerships with our state regional overdose prevention specialists. This is a picture I took in a Chicago library where they have naloxone available. What you can't see in this picture is the box of naloxone on the wall next to the poster. I don't think this is currently available at Tennessee libraries, but it's an example of how creative public health interventions can be. How can our patients in Tennessee access naloxone now? They can get naloxone at pharmacies with a prescription and use their insurance to pay for it. TennCare covers naloxone. For those who are uninsured, the cost is approximately $45 to $75 per prescription, which is probably out of reach for a lot of patients who need this medication. In Tennessee, naloxone is now available from pharmacists without a prescription. For free naloxone, our regional overdose prevention specialists are a great resource. Some health departments provide free naloxone, in particular our larger metro departments. There are also free online resources where naloxone can be mailed. Next, let's talk about fentanyl test strips. These are strips that are designed to detect fentanyl in drugs. They were legalized in Tennessee in 2022. They help people avoid or use less of a substance if it has fentanyl in it. They are available commercially, and also the Tennessee Department of Mental Health and Substance Abuse Services distributes them. The Tennessee Department of Mental Health and Substance Abuse Services distributed 126,000 fentanyl test strips from June of 2022 to June of 2023, with the goal of reducing overdose deaths and empowering people to make safer decisions, with the ultimate goal of connecting them with treatment and recovery resources. They found that 85% of respondents made at least one positive behavior change in relation to the fentanyl test strips, and 94% stated that they felt better able to protect themselves. How can we employ harm reduction strategies in our obstetric settings? This is not a comprehensive list, but a starting point. We don't want people to avoid prenatal care or hospital care. First, we listen. Just listen. Patients are the experts in their own lives and can tell us what they need. Ask what your patient's goals are and understand that their goals may be different from our goals as healthcare providers. Educate on maternal and fetal risks of continued use. Make sure they have all the accurate information they need. This includes medical risks and potential legal and custody risks. But if you don't know, don't hypothesize, as that can lead to fear and avoidance of care. Make your office or hospital a safe space. This includes training all staff on the chronic disease nature of substance use disorder, creating trauma-informed practices and spaces and clinic flow, and making sure consent is truly informed. Discuss all treatment options and offer resources for safer use in your community. Without screening, we don't know who is at risk, and we miss those who need these life-saving interventions. Screening for substance use disorder in pregnancy is foundational. It opens the door for patients to be able to discuss issues they may be having about substances of all types, including alcohol, and to ask questions. ACOG recommends universal screening for substance use in pregnancy at the first prenatal visit. Targeted screening can lead to missed cases and add to stereotype and stigma. ACOG recommends using validated questionnaires for universal screening. We should be screening every patient. Like ACOG, we recommend screening at the first prenatal visit, but also at delivery, since in our systems, patients often deliver at hospitals outside of their prenatal care system or may present with no or limited prenatal care. we need to be using validated screening tools. There are several validated screening tools, and I will give examples of 2 of them. If someone screens positive, we complete the SBIRT, brief intervention and referral to treatment. The NIDA Quick Screen is a validated screening tool. It has not been validated in pregnancy, but it does incorporate tobacco products and includes frequency estimates. This is the 5Ps Plus screening tool. It is free and has been validated in pregnancy. It consists of 5 questions. Did any of your parents have problems with alcohol or drugs? Do any of your friends or peers have problems with alcohol or drug use? Does your partner have a problem with alcohol or drug use? Before you were pregnant, did you have any problems with alcohol or drug use in the past? And in the past month, did you drink alcohol or use other drugs? The NIDA Quick Screen is another validated screening tool. It has not been validated in pregnancy, but it does incorporate tobacco products and includes frequency estimates. Both tests have pluses and minuses, so the best test is the one that works best for you in your system, and the one that can be integrated into your workflow with the least disruption. All patients get screened at their first prenatal visit, and the results of that screening determine if a brief intervention is necessary. Based on that brief intervention, referral to treatment may be indicated. Brief interventions are evidence-based and should be short, 5 to 15 minutes. In pregnancy, we hope to motivate intermittent users to abstain and to provide treatment resources and education for people with moderate to severe use. When we refer to treatment, we consider the substance type and severity of their use. Gestational age can also direct where a person would be optimally treated. Underlying medical and psychiatric comorbidities may influence treatment types and referral pathways. For example, someone using cocaine once a week could be referred for outpatient treatment with an addiction medicine specialist, while someone who is using fentanyl daily at 34 weeks of pregnancy would benefit from inpatient or residential treatment. Of course, your community resources will impact what treatment is available. Substance use disorder treatment settings range from outpatient to long-term residential and sober living. It is not your responsibility as an OB provider to determine the optimal treatment plan, but providing the referral to a specialist that can develop that plan is part of our role as women's health specialists. This is an example of a process map for SBIRT at an initial OB visit from the Illinois Perinatal Quality Collaborative. I like this because built into the process is making sure the patient is seen privately for confidential screening at some point at the visit. This is also essential for domestic violence and safety screening. In this process, those with suspected moderate to severe substance use get referred to an addiction specialist, and those with low to moderate substance use get referred to counseling. And those with occasional use get education around abstinence and pregnancy. This is an example of brief interventions for positive responses to the 5Ps Plus screening tool. In this example, for someone who screens positive for parent, peer, or partner use, the brief intervention is a screen for safety and education on risks of substance use in pregnancy. For a positive screen to past use without present use, the intervention is to review history of substance use, discuss risk of relapse, and review support systems and resources. In addition to reviewing substance use, risks of relapse, and support systems, consideration can be made for urine drug testing with consent from the patient, ensuring that hepatitis C is tested for, and that the patient has naloxone for overdose prevention. If outpatient social work is available within your system, a referral could be placed, or a referral to high-risk obstetric case managers through insurance. Referral for treatment would also be indicated depending on what the present substance use entails. What about urine drug testing? I know that in some places urine drug testing continues to be used in the place of validated screening tools, but we want to continue to advocate for the use of a validated screening tool or questionnaire instead of urine drug testing. Urine drug tests are not designed to be screening tools, and they should only be performed with patient knowledge and consent. It is not uncommon for people to avoid prenatal care due to fears of urine drug testing and the implications of a positive test. With urine drug tests, there are risks of both false positives and false negatives. Common over-the-counter medications, as well as frequently prescribed medications in pregnancy, can cause false positives. Examples of this include ranitidine, labetalol, diphenhydramine, sertraline, and other over-the-counter cold medications, just to name a few. Any positive drug test needs to be sent for confirmatory testing in order to rule out a false positive. Equally as important, a negative drug test does not mean someone is not using substances or at risk for substance use disorder. A negative drug test may mean they have not used within the window of detection for that test. Depending on the substance, that could be a few days of abstinence. Other substances have longer half-lives and may be positive even if the person has not used in several weeks. Marijuana is an example of that. Finally, many synthetic drugs, including some types of fentanyl, xylazine, and nitazenes, are not detectable on commercially available drug tests. A person who is only using fentanyl will not test positive for opioids at all, and they may not even test positive for fentanyl if the type of fentanyl that they are using is a less common synthetic analog. If you are ordering urine drug testing, know your test. Know what it is testing for and what it doesn't test for. And make sure that confirmatory testing is either done reflexively or ordered on any positive test. Ordering urine drug testing without permission destroys patient trust and damages the therapeutic relationship and alliance between clinicians and their patients. Screening can help prevent overdose by identifying our patients who are at risk and providing them with naloxone and referring them to treatment. It also helps us support our patients who are already in treatment. It is important for obstetricians, midwives, family medicine physicians, and nurse practitioners to be familiar with treatment options for opioid use disorder in pregnancy. This includes medications for opioid use disorder, methadone, buprenorphine, and naltrexone, as well as medication-assisted withdrawal or abstinence-based treatment. Medications for opioid use disorder primarily work by their interactions with the opioid receptors. Methadone is a full agonist and so occupies and fully binds the mu-opioid receptors. Buprenorphine is a partial activator of the mu-opioid receptor. It occupies the mu receptor but does not activate it as much as a full opioid agonist. Naltrexone is a mu receptor blocker. It occupies the receptor and prevents activation from other opioids. Methadone has been used for decades in pregnancy, since the 1970s. It is a full opioid agonist and it is long-acting. Taken daily, it prevents withdrawal symptoms and cravings for other shorter-acting opioids, such as heroin and fentanyl. Studies have shown it to increase adherence to prenatal care, improve pregnancy outcomes, and decrease severity of neonatal abstinence syndrome, otherwise known as neonatal opioid withdrawal syndrome, while also increasing the likelihood of baby being discharged home to biological mom. This meta-analysis on methadone efficacy in preventing relapse showed a decrease in opioid use for patients prescribed methadone compared to controls. Methadone requires daily visits to clinic for dosing and is highly regulated by the federal government. And while the number of federally licensed methadone clinics in Tennessee has increased over the past few years, the majority of our counties do not have a methadone clinic. The risk of neonatal opioid withdrawal syndrome from methadone is about 50%. As a partial opioid receptor agonist, buprenorphine has less risk of sedation and is thought to be even protective against overdose. It is an office-based treatment, so tends to be more accessible compared to methadone. Many patients report that they feel normal on buprenorphine. Some studies have shown less severe neonatal abstinence syndrome or neonatal opioid withdrawal syndrome with shorter hospitalization and less morphine requirement for babies exposed to buprenorphine. Because buprenorphine can precipitate withdrawal if opioids are present in a patient's system when they get their first dose, it can be challenging to start buprenorphine. This is especially true in the age of synthetic fentanyl. Buprenorphine may be less effective for people using high doses of IV opioids. In the pivotal MOTHER trial, which was a randomized controlled trial comparing buprenorphine to methadone in pregnancy, buprenorphine had a higher dropout rate and may have had a higher relapse rate. Neonatal opioid withdrawal syndrome rates range in general between 20 to 45% for buprenorphine in pregnancy. These are two studies that looked at opioid relapse comparing buprenorphine to placebo. Both studies showed higher relapse rates in the placebo arm. This study looked at the role of buprenorphine, Vivitrol, and oral naltrexone in overdose rates. The buprenorphine group had the lowest overdose rates. In the first month after buprenorphine discontinuation, their relapse rates were equivalent to those actively on Vivitrol, the naltrexone injection. The highest overdose rates in the study were in the first month after discontinuation of either the oral or injectable naltrexone. This study illustrates the role of medication for opioid use disorder in overdose prevention. Naltrexone is an opioid receptor blocker and comes as a monthly injection or a daily pill. It requires a period of 7 to 14 days of opioid abstinence prior to initiation in order to not precipitate withdrawal. There are only a few studies of naltrexone in pregnancy, but it is likely safe while having less risk of neonatal opioid withdrawal syndrome. Due to its opioid blockade, the injection must be stopped a month prior to surgery, and the oral formulation must be stopped for 72 hours prior to surgery. What about medically assisted withdrawal, also known as detox? Historically, it was thought that this would cause miscarriage or other pregnancy complications. Newer evidence shows that it can be accomplished safely with appropriate supervision and support. Medically assisted withdrawal has the benefits of reducing risk of neonatal opioid withdrawal syndrome, if successful, and reduces theoretical long-term risks of fetal opioid exposure. There is also a decreased risk of interventions by Child Protective Services and may be more supported by family, courts, and community. The primary disadvantages are risk of relapse and risk of overdose. There are not enough residential and longer-term programs that allow children. There are also medical risks of withdrawal without appropriate medical supervision. Ultimately, it is a treatment of a chronic disease with a short-term intervention. Behavioral support is critical for patients whose preference is abstinence-based treatment. Regardless of the treatment path chosen by our patients, stigma contributes to relapse and overdose. How have you seen stigma impact care for pregnant people with substance use disorder? We know from studies that pregnant women have more difficulty accessing medications for opioid use disorder compared to non-pregnant people. Even the very language that we use in the medical record can be stigmatizing. Patients who are labeled as drug abusers are less likely to get referred to treatment compared to those who were described as having a substance use disorder. For years, substance use disorder in general, including opioid use disorder, has been considered a moral weakness or willful choice rather than the chronic medical behavioral health issue that it is. As this thinking shifts, we are seeing more education of healthcare professionals on substance use disorder. We are also seeing more clinicians getting training in addiction medicine. Stigma has caused opioid use disorder treatment to often be siloed from the rest of healthcare. The more that we can incorporate treatment into primary care spaces, whether that is internal medicine, OB/GYN, or family medicine, the more access to life-saving medications people will have. Take time to educate yourself and your staff on language that perpetuates stigma. Using patient-centered language helps fight stigma one interaction at a time. Criminal justice systems and Child Protective Service safety plans have historically failed to consider and incorporate medical treatment recommendations. This makes patients reluctant to engage in treatment sometimes, especially medication-based treatments. We, as medical professionals, can shift the conversation and create change within our communities, within our clinics, departments, and hospitals. We can create an environment where stigma has no place and all people have value. Educational initiatives on overdose prevention for obstetric providers should include education on naloxone, the chronic disease model of substance use disorder, opioid use disorder in pregnancy, harm reduction philosophy, perinatal mood and anxiety disorders, and medication for opioid use disorder. Lastly, motivational interviewing techniques can be game changers for any medical interventions where behavior change is being targeted. Our patients with opioid use disorder and families should be educated on opioid use disorder in pregnancy and the care of the opioid-exposed newborn. Naloxone for overdose prevention, fentanyl test strips and syringe exchange programs in the community, medications for opioid use disorder, community supports, perinatal mood and anxiety disorders, and post-birth warning signs. There are many resources available on this topic, and I have highlighted a few specific to overdose prevention and harm reduction on this slide. In Tennessee, regional overdose prevention specialists can be contacted to conduct trainings for your clinics, hospitals, or even for groups of patients. The Find Help Now Tennessee website is an excellent resource for patients and healthcare professionals. It helps connect people to treatment facilities of all levels that have current openings. The Tennessee Red Line is a hotline that also connects people in need of substance use disorder treatment with resources. TADIS, the organization that runs the Tennessee Red Line, also provides trainings and educational materials on substance use disorder. In conclusion, overdose is the primary cause of preventable pregnancy-associated maternal mortality in Tennessee. The key word here is preventable. We have the power and ability to change this. We can get naloxone into our communities, screen all of our patients for substance use disorder, and connect people to treatment. We can even bring buprenorphine prescribing into our practices. We can acknowledge the inherent worth and dignity of all our patients with substance use disorder and combat stigma within our spheres of influence. What is one action that you can take today? Thank you for taking the time to watch this video. For additional resources and videos, please check out www.tipqc.org.